to try to spark an interest here today and get you to think about research and perhaps where you might want to be and where you want to spend 2 years doing research. The second goal of today is, or the second disclosure I need to say is the title. This title, Research Across the Continuum, it sounds really slick. It's not mine, unfortunately. If you Google it, you'll find lots of papers written on this concept of research across the continuum. You'll find talks given by people from the NIH on this concept. I'm not exactly sure what it means. I think it means that research is changing. The concept of translational research is changing. So what I've always thought of as translational research is sort of, the nerd in the laboratory and the basic science lab pipetting and doing things that I can say nerd because this is what I do, right? Part of my job is this. So it's always this person in the laboratory trying to make some discovery and then taking it to the bedside, right? He or she has discovered some new molecule and they take it to the bedside and give it to patients and they find that cancer is cured. That's great. But honestly, that's not the paradigm today, right? The paradigm today looks a little bit more like this. It's fairly complicated of basic science. You certainly have translational research, but everything is sort of feeding into this concept of translational research, where we have efficacy studies, we have outcomes and effectiveness research, we have informatics research, and all of this really is feeding back into the patient, really kind of making what I think is the new paradigm for the continuum. So that's really what I think this research across the continuum reflects, is this idea that research is changing. It's not just basic science. It's a whole spectrum of activity, but it should all ultimately feed back into the patient. Now, what I wanted to talk about today is what I see as research across the continuum, a little bit in colorectal surgery. Now, I'm going to pick on colorectal surgery today for a couple reasons. One, I'm a colorectal surgeon, and I'm still passionate about colorectal cancer. And two, because it's easy for me to do. I will say that a goal in GI would be for every section, all of the GI surgery groups, to really be focusing research the same way here, as I'm going to highlight today. I think we want to start hitting on all cylinders in each area, whether it's minimally invasive or endocrine or whatever area we're looking at. So I'm just going to take colorectal cancer today as a model, if you will. And so when I think about colorectal cancer, by and large, I love treating this disease, honestly. I love treating patients with colorectal cancer. By and large, it's because we're doing pretty well. So this is just the mortality slide from the American Cancer Society. You see that mortality in general, incidence and death rates in general, is decreasing for colorectal cancer over the years. Now, keep in mind, even though it's decreasing, it's still the second leading cause of cancer-related mortality in the United States, and it's the third most common cancer in both sexes. So we have a long way to go, but we're getting better. I suppose if we put our heads together, we could come up with several reasons why we're getting better. But I think we can generally lump them here. Prevention, we're better at prevention. We've got polypectomies, colonoscopy started back in the 1960s. We seem to have a good idea of how to do colonoscopy and how to do polypectomies. So we seem to be catching these tumors earlier and preventing cancers. We're better at diagnosis. We're diagnosing patients at earlier stages when they are curable. And finally, we've got some improvements in treatment where we've got better surgery, we've got better chemotherapy. But again, it's safe to say we can continue to improve. So the question is then, how might we do this from a research perspective? How can we use research to really start to improve our treatment and our outcomes in colorectal cancer? Now, what I'm going to do now is kind of go into kind of breaking it down in each sort of lump, in each sort of bucket, and talk about work going on. I'm not really going to focus a whole lot on treatment other than perhaps how surgery can lead to bad outcomes. Other than that, so there is some work going on in the laboratory looking at chemotherapy and how to use different agents to synergize our current chemotherapeutics. It's really interesting work, but it's a little bit too infant to really talk about in public. So I'm not going to talk a lot about that. To start though, why don't I talk about prevention and why I think colorectal cancer is sort of an ideal cancer for preventive therapy. If you remember this from medical school, this is the Vogelgram. Bert Vogelstein first sort of described this adenoma to carcinoma sequence, right? The idea is that you have normal epithelium through a series of consecutive mutations. You develop gives rise to some type of an adenoma, a polyp. This small adenoma grows into an advanced adenoma and eventually degenerates into a colon cancer after enough time and consecutive mutations. Now, this is sort of an old model, right? We know that probably 75% of colon cancers actually still do develop through this adenoma to carcinoma sequence. The other 25% maybe have some different mutations. Perhaps there's a brief interval of an adenoma, but then right into a carcinoma. So there's certainly some changing thought here. But by and large, this is the model. And you can imagine now that chemoprevention becomes fairly attractive, or polypectomy for that matter. This is why polypectomy works for colon cancer. This is why screening colonoscopy works. We catch patients here, remove the polyp, they don't progress to here. It just makes sense. Chemoprevention, on the other hand, works the same way, right? We interact at any stage along the line to prevent this carcinoma. So as we think about chemopreventives and chemical chemoprevention in particular, we have to consider these factors if we're considering ideal chemopreventives. So first of all, an ideal chemopreventive should have little or no toxicity, primarily because we're treating normal humans. We're treating normal patients who have no symptoms. We don't want to give them symptoms. We don't want to give them something that kills their bone marrow or all their hair falls out for a chemopreventive. That would be, I think, bad form. It should be highly efficacious in multiple sites. It would be ideal if you could give somebody one pill and prevent colon cancer, breast cancer, prostate cancer, right? That would be ideal. Perhaps pie in the sky would be great. It should be orally consumable. You shouldn't have to take it per rectum or something terrible like that. It should have a known mechanism of action. This is just meaning that most of what we have for chemopreventive right now are quite dirty. They do lots of things. We don't really know the mechanism. Ideally, this would be a drug or a chemical that targets one pathway. It should be low cost, of course, and then it should be acceptable. And what that means is we shouldn't have to chop down every rainforest in the world to get it. We shouldn't have to kill every spotted owl to get it, right? We should be able to produce it in the lab, synthesize it, something like that. It should be acceptable to everybody. It should be green. So most of the work thus far on chemoprevention really has focused around aspirin and other COX-2 inhibitors. Several randomized controlled trials. This is just a meta-analysis of aspirin in chemoprevention. And the short story is it works. The aspirin does work to prevent colon and rectal polyps. There becomes a few issues with aspirin. One is who should take it. Probably not everybody, because not everyone's at high risk. So how do we start to sort this out? It's a relatively safe drug, as we all know, but there are some data that says there's an increased risk for strokes out of these randomized controlled trials. Of course, there's bleeding risks. There's some, perhaps selective COX-2 inhibitors are safer than aspirin, and they've also been found to reduce risk, but they also have an increased risk for ulcer disease, increased risk for serious cardiovascular events. So none of these particular agents are perfect. So we've got room to improve. And in fact, the overall risk-benefit ratio really doesn't favor those patients who aren't at high, moderate, or high risk. So the question is, how do we get something better? Well, of course, natural products is where everyone wants to go. And in fact, when you start to read chemopreventive literature, I'll just tell you it's terrible. It's terrible science by and large. It's a bunch of people who have discovered some new chemical. They've purified some chemical out of some plant and they throw it on cells and it kills cells. Then they throw it in a mouse and it prevents some tumor growth in a mouse. And because it's natural, they put it right into clinical trials. They don't really know what the mechanism is. In fact, when you read how it's working, it can usually turn out to activate or inhibit whatever your favorite pathway is. So it's just terrible science. But it's very attractive, right? It's been used, these products have largely been used for hundreds of years. A variety of foods and substances have been correlated with reduced risks. And there's a wide variety of biologically active chemicals in all of these substances. So phenolics, flavonoids, alkaloids, all these things are biologically active. And the thought is they're natural, so they must be safe. In fact, some of the work that we focus on are flavonoids. And I just Googled my favorite flavonoid, something called indole-3-carbinol. And we pulled this off of WebMD, and you look at indole-3-carbinol, what you find is that, in fact, it does everything. It's a wonder drug. You can go down to GNC and buy it and start taking it today, and perhaps you should, or perhaps not. I don't know the answer right now, but I'm going to share some data with you that might suggest maybe it's good, maybe it's bad. We don't really know. But you can see that you can use it for fibromyalgia. How awesome would that be? You can use it for tumors inside the voice box, respiratory tract, tumors caused by HPV, abnormal cell growth in the cervix, and for systemic lupus. You can use it to detoxify the intestines and liver. So, I mean, might put Joe Tector out of business with his liver, with his intestinal transplants. We're going to detoxify people. And this is awesome stuff, right? So the question, I guess, is how does it work, and what do we really know about it? And I'm going to focus a little bit on this because it works through a pathway called the Aryl hydrocarbon receptor. And this is what I study in the laboratory. It's a long story as to how I got to this pathway. It turns out the aryl hydrocarbon receptor is an environmentally responsive protein. It binds to largely environmental toxicants. That's what it's known to do. It's a cytosolic receptor that binds to these toxicants and activates cytochromes to clear out the toxicants. That's largely what it's been known to do. We know that when you activate the AHR in the liver, you can actually induce liver toxicity. For example, it binds to acetaminophen. And acetaminophen kills your liver in an AHR-dependent fashion, it turns out. Dioxin's the same way. It binds to dioxin's a chemical that's produced from from paper production. It's found very commonly in streams where paper is produced. Dioxin at high levels will also kill your liver in an AHR-dependent fashion. So what we know is that when AHR is bound by its ligand, it moves into the nucleus and activates the transcription of a number of genes. Those genes largely can fall into this adaptive pathway. This is the cytochrome P450s. They're just purely to clear out these toxicants. It also plays some role in development, and this is a bit of a black box here. Basically what we know is that mice that are null for the aryl hydrocarbon receptor aren't quite normal. They have a patent ductus venosus, they have this portal venous shunt, they have some abnormal kidneys. They're just not quite normal. If they look fairly normal, they behave fairly normally, but they're not quite normal when you start looking at them grossly. It also plays some role in immunity. This is largely intestinal immunity or mucosal-based immunity. So it's very interesting. Makes some sense. It turns out toxins in cigarette smoke activate the aryl hydrocarbon receptor. So it makes some sense that AHR is playing a role here. Again, it's a bit of a black box, however. But indole-3-carbinol does work through this pathway. So then we have to ask ourselves, if you think you can take indole-3-carbinol, we know that AHR sort of activates, when active in the liver, can induce liver toxicity. So is activation of the AHR always good? It turns out we looked at a paper, we studied a paper, or we published a paper in which we demonstrated that activation of AHR in the liver promotes liver tumorigenesis. So perhaps AHR activity is not always good. Based on this data, though, based on these early data looking at activity of AHR in the liver, we sort of hypothesized then that AHR is an oncogene. So if we lose AHR, if you activate AHR, it drives tumorigenesis. If we lose it, perhaps it'd be beneficial. That's sort of the genesis of all of my research. So I started with the simple hypothesis in the beginning that loss of AHR in the large intestine result in a decreased sensitivity to colon tumor induction, right? So in other words, it's serving as an oncogene. So what we did is we took some mice and we induced colon tumors in them. So we treated them with azoxymethane, which is a tumor initiator. We followed that with dextrans sodium sulfate, which is a tumor promoter. Just inflammatory. This is sort of an inflammatory model. Think of it like IBD. same sort of thing. And then we just waited. We waited for 4 months, and then we stacked all the mice and counted tumor numbers. What we found is that, in fact, our wild-type mice, our tumor incidence was around 68%. In our nulls, the incidence was 100%. So our hypothesis was that this should be lower than this, and in fact, what we found is it's higher. Interesting. Either observation is good, I guess, so that was interesting. It just didn't quite fill our hypothesis. And the other thing was that there were more tumors on average per mouse in the AHR nulls. So what we then set up, it turns out, was a situation in which the AHR in one setting, the liver, is an oncogene, and perhaps in another, in the intestine, it's a tumor suppressor gene. That's kind of classic, a classic oncogene tumor suppressor gene, or biphasic protein. It happens all the time, so this made good sense. But it made us think that then perhaps if we activated it, so if we treated mice with some AHR agonist, perhaps we could prevent colon tumors, right? It's all just sort of fits. So what we found here is we took wild-type mice, we put them on a controlled diet, or a diet with indole 3-carbinol. What we found is a rate of tumorigenesis, tumor incidence, 83% versus 7%. And in our AHR nulls, all mice had 100% regardless of diet, just suggesting this is AHR dependent now. So indole 3-carbinol is functioning in AHR dependent fashion. We see the tumor numbers grossly reduced as well. So on average, around 4 tumors in the wild-type mice on a controlled diet, compared to the mean number just over 0 in mode is 0, it turns out. So in the AHR nulls, no difference in tumor numbers. So again, all we concluded here is that indole 3-carbinol prevents tumors in mice. Another study that prevents tumors in mice. That's great work. And it does so in an AHR-dependent fashion. So the next question might be then, well, where are we going with this? But first of all, lots of basic science to be done, stuff that perhaps some of you aren't interested in, but I hope some of you will be. Lots of interesting stuff. One is to try to understand the cell autonomy of the observation. That is, where is AHR functioning? Is it functioning in the immune cells? Is it functioning in the mucosal cells? Where is this requirement? Better understand the role of indole 3-carbinol in modulating inflammation. It turns out in this inflammatory model, a lot of what AHR is doing seems to be reducing inflammation. We need to understand that. And perhaps it's useful in patients with IBD as well. From a human perspective, I think it makes sense to go ahead and start a clinical trial. Indole 3-carbinol, you saw WebMD says it's safe, it cures everything. So what the hell? Let's start a clinical trial. And also try to understand how it interacts with the microbiome, I think, is some of the next steps. Well, this is all great if you really want to focus on prevention, but we also are doing some work around diagnosis. So let's talk just for a brief minute about how we currently diagnose and where might we go in the future. So right now, colonoscopy is, of course, the gold standard for diagnosis of colon cancer. Diagnosis and prevention, in fact. But there are other markers there's other tests on the market that can be used. So fecal DNA blood test, this is the Exact Science Cologuard test, right? Again, it turns out Bert Vogelstein discovered this as well. This is basically looking at methylated DNA out of cells that are in the stool. So we're using PCR to amplify this DNA and detecting methylated DNA and fecal blood as well. 92% sensitive for cancer. It's only about 69% sensitive for high-grade dysplasia. So if you're walking in the door with cancer, you'll be pretty lucky. Cologuard would be a pretty good test. What it won't tell you that accurately, though, is if you have a polyp that's high risk for going on to develop cancer. And that's really what we want to find, right? Where might Cologuard fit in the scheme? Well, it might fit in patients who really don't ever want to have a colonoscopy. Might be not unreasonable. It might fit in patients who don't have access to colonoscopy, right? So the bushland of Alaska or out where I'm from, out west, where there really aren't gastroenterologists available around every corner. So it may fit out there. Here in Birmingham, I'm not so sure it fits, but there might be pockets of patients that would be candidates. Other serological markers, cell-free DNA, Septin9. This is available. It's not that accurate. It's really not that great of a test, so it's not a standalone test, but it might be a test that you can couple with something else. There's some work going on in protein profiling, so looking at the profile of proteins in the serum, and also some novel imaging, and that's really what I want to talk about, because this is work that's going on right here at UAB. So remember, our goals ultimately are to improve outcomes of patients undergoing this cancer treatment. And to do this, I think we can work on diagnosis and detection, and also aid in prognosis. We also want to stay out on that cutting edge of therapy and prevention. So part of our goal here of diagnosis started back in Wisconsin when I met this fellow. This is a guy named Mike Sussman. He's crazy as a loon. He's a classic scientist. He has another thought every 30 seconds or so. He's one of the smartest guys I've ever met. But he had this brilliant, he worked with this brilliant graduate student, Melanie Ivansy, who ended up working as a postdoc in my lab. They looked in rats that had a risk for colon polyps based on an APC mutation. And they took serum from these rats sequentially over time, and they profiled these rats using mass spec. What Melanie found is that, in fact, a battery of proteins did change over time as the rats developed more and more polyps. So just suggesting that these proteins correlated with tumor formation in the rats. They published that paper, and then they came to me and said, hey, Greg, can we do this study in humans? And I, of course, said, yeah, we can do it in humans, and we should. So we did a very simple design. Probably anybody would have come up with the same thing. We first said, well, look, ideally we want to detect polyps, but why don't we start with something that we know is going to be in existence, and that's patients with cancer, and see, does it correlate with cancer first? A polyp detection study is going to be much more difficult, need a lot more patients. A cancer detection study, perhaps we can detect it in 100 patients or fewer. So we just took patients with a known diagnosis of cancer, we took their blood, and then we did this targeted mass spec. I'm not going to pretend to know how this works, to be honest with you. But basically what they're doing is using the mass spec machine, the mass spectrometer, to detect specific proteins. Okay, you can do the same thing with immunohistochemistry or Western blot or whatever. They're just using a mass spec to do it. Lo and behold, as our control, we took patients who were asymptomatic, having normal colonoscopies. That was our control. Lo and behold, what we found is that the proteins that were elevated in the rat are elevated in humans with colon cancer. Now, it turns out the proteins that were decreased in the rat were also decreased in humans with colon cancer, suggesting that this protein profile may actually work. Now, I personally think that's pretty exciting. It may, in fact, as we do more work and we confirm the results. The problem with Wisconsin, there's lots of problems with Wisconsin, but one problem with Wisconsin is that every patient right there is white. So 100% of our patients are white. So it's a bunch of white men, but we may have well done the study in the VA. So we have no idea how useful this study really is right now, how useful this test is really going to be. We need to get more patients in the studies. We're open that study here at UAB. We're going to start accruing patients very soon and start to look at this protein profile in humans in a bigger human population of patients. As we think about, though, the goals of surgical therapy, it's really, I think we can say that it's these two things: treat the primary, remove that segment, that affected segment of tumor, and also accurately stage, so remove lymph nodes. In fact, one thing that I'm really excited about is this idea of, if we could preoperatively accurately stage patients, we could then start investigating novel treatments, novel surgical treatments, right? Ways that we can remove the primary that don't involve removing segments of colons, right? So could we look at some type of endoscopic removal, something like that? I'm very excited about this because I think it's really the future. Well, it turns out some of these proteins correlate with stage, which I find the most exciting thing about these protein profiles. So if you look, here's CRP, for example. Don't ask me why CRP, and let's not get into what CRP does or doesn't do. But if you look at it, it seems to correlate with stage 1, stage 2, stage 3. Here's this protein CD44. It's decreasing as stage increases. DPP4, there may be a correlation. CDH2 may be a correlation. There's a couple of others that there may be correlations. Now, none of these p-values are significant. Again, small patient numbers. We need to do more work. But I think this is where the real power of this test is going to be here, is ultimately, can we predict stage? If you couple this perhaps with some other novel imaging agent, perhaps then we really could change the way we're working. So one of the things Jamie is doing is looking at using MRI to try to predict stage. So think about this. This is our current paradigm. New diagnosis of colon cancer, patients go off to surgery. If we could somehow use some type of an MRI nodal staging test or protein profile to predict with some probability lymph node involvement, then perhaps we could move into this endoscopic therapy, right? So if patients are candidate for complex endoscopic removal, then we can save colon length. If they're not, then we go ahead and do colonoscopy, then we go ahead and do a colectomy. But hopefully we could save colon length. Now, it turns out this MRI is pretty exciting, and we have this available here at UAB. It's an MRI fused with PET. Now, we've all seen the PET CT scans, right? And you're kind of used to looking at the CT, and you're used to looking at the CT where you don't see tumor, right? And you fuse it with the PET, and you see these bright spots, and you kind of think there's liver there. Well, an MRI PET, you can fuse it with a diffusion-weighted MRI, and you actually start to see down to the tissue microstructure that MRI gives you the power to see. So the idea here is that it's pretty powerful technology. Now, again, I'm not a radiologist. I don't make nearly enough money to sit in a dark room and read x-rays. So I'm not a radiologist. So I'm not going to say that I understand the differences between these and get all excited that I can detect this. What interests me the most is that there are some novel contrast agents that are excluded theoretically from lymph nodes that are positive for cancer with this MRI technology. So can we now start to use MRI with its contrast agent, see a node that's enhanced compared to a node that's not enhanced, go and pluck that node that's not enhanced out and see that in fact it has cancer in it. So now we can start to say with some degree of probability that this node that isn't lighting up on MRI is actually positive for cancer, right? So it allows us to really predict cancer involvement preoperatively. Now this is another study that's going to be opening here at UAB very soon, led by Dr. Cannon. And really this is the question: can PET-MR accurately predict lymph node involvement of primary colorectal cancer? It's too early to say. I've been trying to do this study up in Wisconsin for several years, haven't been able to get people involved. Come down here, Dr. Cannon is totally on board. She's totally jacked about it. It's going to be our leader pushing this study forward. I think this is going to be a great work and going to lead us into the future, I think, of surgery, in my mind. So that really leads us into treatment. What are we doing to really try to improve treatment? Clearly, surgery plays an important role in treatment of colorectal cancer. It always is going to, no matter what we do, we're going to still have to take out cancers. But it's important that we recognize as surgeons that what we do to patients is actually hurting patients. So this is the paper I published back in 2009. The point of the slide isn't that laparoscopy and open here. The point of the slide is look at the numbers. 25% of patients have complications and have open colectomies. Heck, 15% of patients have laparoscopic procedures have complications, having laparoscopic colectomies. This is a ridiculous number, right? You wouldn't go to if you went to school, if you went to a college and 25% of the students failed, you probably wouldn't want to go to that college. People would be trying to shut down the college for one reason or another, right? Here what we're doing is telling patients, no, come to us, we'll take out your colon. 25% of you, we're actually going to hurt you while we do it, right? We clearly have to get better here. I think that's the take-home message in my mind. So how do we get better, and why does it matter? So first of all, we looked at short-term outcomes, and we looked at this as far as can we predict, do these short-term outcomes impact long-term survival, right? We as surgeons I think one thing that's always bothered me a little bit is perhaps not everybody in the room, but you know that this exists. You can talk to surgeons and they say, well, the patient survived, so I guess we did okay, even though they've got this open wound and a DVT and they leave on Coumadin or whatever, right? I guess they still survive, so we're doing all right. So they tend not to see things long term, they tend to see it in the short term. So we wanted to ask, do these short-term outcomes actually correlate with some type of a long-term survival or long-term outcome, right? Cancer outcome. So what we looked at is just basically patients with complications who have rectal cancer surgery and those without, and we ask, what are their survivals? It turns out that patients who have complications, so if we look at adjuvant therapy less than 8 weeks or greater than 8 weeks, 25% of patients had complications less than 8 weeks. 44% had complications who had adjuvant therapy after that 8-week window. We know that people who get chemotherapy after 8 weeks do worse, right? So that's in general what we know. And in fact, that turns out to be true in this study with patients with rectal cancer. If they got their chemotherapy less than 8 weeks, they did better. 8 to 12, greater than 12, they did worse long term. We did do a multivariable analysis, and it turns out that complications, postoperative complications, was a significant predictor of poor long-term survival. Now, there are lots of problems with the paper. I'm not trying to hold this paper up as sort of, this proves by all stretch of imagination that complications lead to worse long-term outcomes. It's not at all the point of the paper. The point of the paper is to get people thinking that, in fact, we do need to worry about these short-term outcomes. We do need to focus our time on this. One of the great things about coming here is that we've got people like Dr. Morris, right? She knows the importance of this. She knows that the struggle is real, and she's all about trying to improve outcomes. So out of 3 million patients in the NSQIP database from 2005 to 2013, 3 million basically who've undergone some type of general surgery procedure, 13.1% have at least one complication. If we look in colon surgery, 14,000 patients for colon cancer, 20% have at least one postoperative complication. So the struggle is clearly real. We have to do something better. Melanie published a paper last year just looking at the way patients are bowel prepped, and if bowel prep actually does or doesn't correlate with outcomes. And in fact, what she showed, and the take-home message from this paper, is that if you're going to bowel prep patients, we need to be using antibiotics. Patients who had a bowel prep with antibiotics did better than patients who did better. They had improved short-term outcomes. To tell you the truth, this paper almost single-handedly brought back the Nichols-Condon prep. People are now going, yeah, well, if we're going to bowel prep patients, we need to be using antibiotics. And we recognize that it makes some people nauseated and it makes some patients vomit, but it's probably better for them in the long term. So it really has changed the way we practice. I think it's that type of work that really highlights that continuum of research. Another great thing about Cummings, we get to work with guys like Dan Chu. Everyone loves Dan Chu, and this is partly why. He's a guy who is completely focused on making a difference in patients. So one of the things that he's done, as you all know, is implement this enhanced recovery after surgery pathway. This is impressive that he was able to get this done. It's a tremendous amount of work to change the way people practice and to get people to accept this idea that we can feed patients immediately post-op and we can get patients out of the hospital on post-operative day 2 or 3. He did it through this sort of classic PDCA cycle, working through this classic quality improvement PDCA cycle. He identified his key champions in the multidisciplinary team. He assembled his task force, constructed his protocols. He did a pilot study in this controlled manner to really gain preliminary data. This is all about buy-in. It really takes one champion. It's not a one-person job, but it takes one person to start to light the fire and to then move the fire and make the fire bigger, to stoke it. Right? As the fire gets bigger, it continues to build and continues to burn based on these champions that he's identified in his multidisciplinary team. But it's Dan who actually lit it and moved it and got it growing. Right? That's the impressive part here. This is a key point here. You got to get this pilot study. You got to get these early wins. Get people involved. Right? Get people behind it. You got to go back. Part of your PDCA cycle, you see it's a cycle, it's continually. You're always planning, you're always repeating. You're looking what can we do better, educate and troubleshoot. And then you try to implement it widespread. What he's found, as you all know, is that length of stay is reduced. There's no doubt about it. And this comes not at the effect of increasing readmissions or increasing complications. It's simply reducing length of stay. There's some even more interesting data in here that he and Tyler have been looking at is that it's actually changed the equity of care as well, right? So when you look at disparity in care, it's pretty clear that the care we provide is disparate to different races. I have no idea why. don't understand it. I don't think it's anything that's targeted by any stretch of the imagination or that's meant to occur, but there's pretty clearly some disparity in outcomes. This enhanced recovery after surgery pathway has seemed to eliminate it, and if anything, improve the equity of care. It's really impressive, the data are. The last part I want to talk about is this fellow here. This is a guy named Joshua Richmond. I don't know if many of you know him. He's a full professor, tenured professor in the department. He's also in the division. He works on something called natural language processing. I'm just going to throw this out here. I have no idea what this is, okay? It's really impressive. It's really interesting, but I don't understand it at all. I had to sit down with Joshua and just say, hey, tell me what natural language processing is exactly. Turns out it's a technique to extract usable information from unstructured clinic notes. I have no idea how he does it, but it's really hard, and it's all really focused around this idea of quality measure development, right? This is something that we all know exists. For those of you who aren't in practice, it's going to be right in your face very soon. This idea that you have to deliver care that's quality, that's high quality, and it's defined by somebody who's not you, right? That's their quality. So it might be a metric that you don't think is important. It doesn't matter, but it's how you have to deliver care. Natural language processing then is really designed to sort of help with this process of developing these measures. The basic problem is that the measure development largely relies on electronic data. It relies on electronic data because it's simple, it's inexpensive, it can be automated, it's less nuanced. It's by and large a yes, no, it's a binary type thing. Did you get antibiotics? Yes, no, right? Did they come before 1 hour prior to incision? Yes, no. You can't really nuance that. It's a yes, no answer. Chart abstraction is probably better. NSQIP, for example, it's better quality data, so we can look at wound infection rates, but it requires somebody to really be going into the data, going into the patient chart and looking at it if we want to get accurate. The problem with it's really expensive. It's complicated. It is nuanced, right? We've got these pretty high-level nurses who are abstracting our data. They're reading the chart. They're trying to figure out, did the patient really have a wound infection or not? It's not based on an ICD-9 code, which the automated data is based on ICD-9 codes. This is very nuanced stuff out of NSQIP. Because it's expensive, you can't abstract every patient. You know that NSQIP is this systematic sampling. About 20% of patients are included is all. So you can't abstract every patient. Using something like natural language processing, perhaps we could abstract every patient. We could automate it, and we automate it based on these ideas of machine learning. Again, I'm talking about stuff I really don't understand, but I've Googled these things, and this is what I come up with. But the reason to have this kind of in your knowledge base is because machine learning or big data analysis is all about these two statistical tests, and others obviously, but these are two types of tests that we can use to investigate these large data sets and do things like natural language processing. So Bayes networks, it really allows for identification of interrelationships between random variables and their conditional dependencies. So an idea might be that given symptoms, you can calculate the probability of having a disease, right, based solely on the symptoms. A Markov chain model, on the other hand, is the probability of moving from one state to another dependent only on the current state. So the Markov property is this idea of memorylessness, right? So why is all of this type of stuff important, and what can we do with these types of things that perhaps we can wrap our heads around? So one thing we can do is this, and I think a lot of Joshua's work can be applied here. So in NSQIP from 05 to 11, there are 957,000 general surgery cases. 15% suffered at least one complication. 6% suffered more than one. I got interested in this concept of multiple complications, or this problem of multiple complications, because those of us who take care of patients, like you guys over here on the left-hand side of the room, can recognize that you see patients, they come in, they're all equally sick, right? They all look terrible on paper. Some fly through, some fall into this huge hole, and you have no idea what happened, right? They have one complication, and that complication begets another, begets another, begets another. It's like this snowball effect of complications. That's really why I got into this work, is to try to say, can we put some pattern, some structure around these complications? So to do that, the first thing we did is just say multiple complications are important, okay, duh, right? A patient who has no complications, they do well. One complication, they do a little less well. Multiple complications, they do poorly. They have a 5 times longer length of stay. They have a 10 times higher rate of reoperation. They have a 10 or 12 times higher mortality rate, okay? And the work-related RVUs are higher. So this is problematic, multiple complications. And it's 6% of our patients here who underwent general surgery procedures. So it's a problem. We applied a Bayes network analysis to this group, and what we found is that, in fact, the complications are related, okay? So here's an example. So we take weaning failure. Weaning failure is related to all these other complications, okay? Now, the direction of these arrows, it turns out it doesn't matter. We're not saying that weaning failure leads to septic shock. It could be both ways. So it's not directionality here. All it's saying is there's a relationship. So in the Bayes network, this is a node. These are the lines that are leading to another node. And all it's saying is that there's a relationship here. We don't know exactly how they're related, just that they are related. Pretty interesting. Now, the next study we did was to actually then apply a Markov chain model to these relationships and say, what's the likelihood of moving from one complication to the next given your current state? Okay, so given that you have a wound infection, what's the likelihood you move on to a wound dehiscence or something like that? So that was the next study we did. And to show this, we just plotted it out in a heat map. And so just to walk you through one example, for example, here, let's take deep superficial surgical site infection. And as we look up, blue, there's no relationship, or actually blue, it's an inverse relationship. It's protective. And as you get a darker red, it's a deep SSI. As you get a darker red, it's related. So here's an example where deep SSI, and let's just look here. Where's wound dehiscence? Wound disruption, deep SSI. Look at the intensity of the red. There's a relationship. We know that, so it's nice to prove that, right? So we've proven that now in our model. So that's the kind of thing that a Markov chain model can do for us. Now, I started this all by talking about natural language processing with Joshua and how this might all be applied. Well, perhaps what we can do is we can apply to the EMR some type of a predictive model using natural language processing or these other complicated statistical methods to start to predict automatically who's at risk, right? So where are we going in next steps? Well, we're going, I think Melanie's working on this collaboration with geriatrics to improve outcomes in the elderly. It's going to be very exciting work, no doubt. It's just an extension of her database type analyses, moving out into the clinical trials arena. We're improving disparity through practice change. Dan is really focusing now on how to improve disparities and how to understand the observation, not just that it's there, not just that we're improving disparities, but rather why, and also what parts of this pathway are really relevant. That's another very exciting area of investigation. And I think we can prevent complications through prediction, and I think Josh was interested in looking at this and how do we build in predictive models using these complex statistical methods of natural language processing and others to really start to predict people who are at risk for these problems. I think the bottom line for me is research across the continuum really involves moving everything into clinical trials, all of our observations. Let's put them into practice. Let's see if we can't actually change what we're doing for the better. And that's really it for me. And at the end of this, what I told you is that my hope is that we can get some of you interested in thinking about these projects, not just for the short term, but actually for the long term. Think about where do I want to be 10, 15 years from now? How do I want to change the world? What mark do I want to leave on patient care? So we need right now innovative young people. We need you to lead the charge. So talk to any one of us afterwards, and I'm sure that anybody has an idea to get you leading the charge. So with that, I'm going to stop and take any questions you might have. And thanks again for everything. Appreciate it.